And you mentioned things like nutrient deficiencies. That's something that's really interesting to me because, correct me if I'm wrong, if you take, let's take a B12 deficiency, for
Mm-hmm.
example, I know that something like an omeprazole, for instance, might impact your ability to utilize B12.
Mm-hmm.
Um, but then when patients go to the hospital, their B12 levels might be normal, but that's not necessarily saying how B12 is being utilized in their system.
Yep.
And then B12 deficiency or lack of utilization has a lot of other cascading effects, such as,
Mm-hmm.
eye issues, mood things. And so patients with obesity and all of these other cascading kind of results might be seeing different specialists.
Mm-hmm.
So how do you, as a general practitioner, kind of bring all of these things together? Because then we see this information siloed. Someone
Yeah.
goes to gets their labs run, and they're like, "Oh, your B12 is fine," but is it really? Like, how do we get around those things to kind of pin down the problem, as opposed to, saying, "Oh, you're fine over here. These numbers are good," but we're kind of circling the drain on the real issue.
Yeah, so I think one of the jobs of a primary care or a general practitioner is to distill all of that information and put it into one overarching thing that's easy for the patient to understand and also for us as providers to understand as well. So there's two kind of nuanced things about that. So there's always like what a lab like range says is normal, but what we know is clinically optimal. And then also like you got to go by objective data and subjective data, like what the patient is telling you. So for instance, if I have a patient who comes in and their B12 is in the 300s, on our labs, it might say that's correct. And every lab, depending on where you go, will have different normal ranges because it's based off the population of people that go there and the standard deviation. And that also takes into account people who have undiagnosed deficiencies. So you have to take all of that into consideration. But I know that clinically, people with a B12 greater than 500 do better than if it's still clinically normal but less than that. So I aim to get people's B12s greater than 500. But then you also have to think about what is the patient saying. Are they having anxiety? Are they having pins and needles? Are they having mood swings? Are they fatigued? If they're having those things and their B12 is less than 500, we should treat. So it's about taking what the patient is saying is concerning them and bothering them, and if it's fitting what you know about a deficiency, and also knowing the difference between what a lab normal is and what like an optimal number is for everything that we check in our blood work.
As far as patients advocating for themselves go, or even, for other physicians, whether they're ER physicians or what have you, are there other tests to determine if the nutrient is being utilized by the body versus simply present in the bloodstream?
That's interesting. So I would say in conventional medicine, we have some other markers that we look at. So for instance, for B12 and folate, we look at levels of homocysteine and methylmalonic acid, long, big names, but they are downstream metabolites in some of the major pathways that these vitamins are used in. So you can see if there is actually any downstream effect of a potential deficiency by checking those levels. I would say in we call it complementary medicine or like functional medicine. They will do stool tests and saliva tests to actually see more in depth. I personally believe in those things. It's hard to get those things ordered for patients. They often have to pay out of pocket. But yes, I would say in conventional, like allopathic medicine, there are some downstream metabolites that we can check to see if there's truly a deficiency. But I think a broader take is done by our more functional, natural medicine counterparts who test these things in the stool and in saliva as well.